Professor Lee is now the professor of the Department of Surgery of the National Taiwan University Hospital, and he's going to give us a talk on the treatment of double cancer of the esophagus and oropharynx, the experience of the National Taiwan University Hospital. Let's welcome Professor Lee.
Thank you, I'm sorry I have to apologize because my originally I received the information assigned the topic as supracarina, but last time I found it is infracarina. So I moved my topic to focus more on infracarina, and I also had also mentioned about some higher condition cancer. So today my talk is in our experience presentation.
左肩右
右
肩，
肩好，那是相同的。
对。
please.
你可以直接按右肩试试看。对。
In Taiwan, esophagus cancer is one of the cancer that uprising instance, and more this phenomenon is more prominent in other cancer. Is especially very important, especially for the cell type of squamous. As we can see, the adenocarcinoma, the incidence rate remains almost the same in the last decades. And as for Taiwanese, the some of the environmental risk factor is famous, and as we know, the smoking is related to the risk of esophageal cancer. And also for ethanol is important. Also for the hypopharynx or oral cancer, and also it is important for esophageal cancer. And also for the drinking alcohol is another factor. So combine these factors together, the incidence rate can synergistically increase by the three risk factors. What is important that because this is the showing that the consumption of alcohol, ethanol, and cigarettes is increasing in the last 2 decades. Especially, we can see the consumption of ethanol is increasing, especially more than the smoking and the drinking. And this is how it is important. It will make the cancer pattern, disease pattern, different, especially for we treat for esophageal cancer. This is our national study that control is compared for the control the incidence for large population, the incidence rate of, and in that case, combined with esophageal cancer is just only less than 0.4. But for the patient with oral cancer, the incidence rate is uprising. And for the oral cancer, oropharynx, hypopharynx, which we know the incidence of esophageal cancer can be increased. So can be uprising to the 24 or 44 or even especially the hypopharynx is especially high. So the important this is why we getting here together to discuss this difficult situation. This is totally different from we learn from textbook or from learn from our teacher. And I think our experience is still limited. We are still learning about it. As this case, for example, is 51 male patient. He had two types of cancer. One is esophageal cancer. It's located in the upper third, and the clinical staging is T3 and 2. And also, in addition to that, he has hypopharyngeal cancer. But fortunately, his local lesion there is an early lesion at T1, clinical T1 stage. But it seems that there is the local has lymph node metastasis around the neck. So for handling such patients, we usually, because we can more easily handle the lesion, so at first we decide to handle the hypopharynx at first. At first we do the lymph node dissection and first we give the lymph node dissection with laryngeal microscopy surgery for the hypopharyngeal lesion, and after that we think the local control, we have the confidence in the local control of the lung cancer, then we go forward for the locally advanced disease of the esophagus. We give, according to our hospital, we give a neoadjuvant setting with 40 grade and with 20 fractions. And after 6 weeks, he received a VAS as a total hysterectomy and cervical and two-side esophageal gastrostomy. And for the local lesion, also the patient received a boosting, a tumor boost, 3,000 centigrade. And unfortunately, the patient, 6 months later, he had left neck lymph node recurrence. So for this patient, we give another lymph node dissection and followed by local radiation for 4,000 centigrade. And now the patient, the 2 years passed. Now the patient are free from disease until now. This is the first case with a high location of the esophagus. Next. Another example is that if the tumor is located in the lower position, and this case, for example, the patient has synchronously with esophageal cancer in the middle third and is 29 centimeter below the incisor. The clinical staging is T3, F1, and F0. And it seems that they seems resectable. And unfortunately, he also has the hypopharyngeal cancer. The clinical staging is T1, N0, and M0. Because this is the early lesion and actually this patient is referred from the other hospital. He received the chemo radiation and go to our hospital to receive surgery. So after the chemo radiation, so this patient received a chemo radiation and had a hypopharynx. Give the definitive dose, 6,600 centigrade. And for esophagus, he received neoadjuvant setting is 400 centigrade. It is our protocol. And after the completion of the chemo radiation, we evaluate all the lesions. It seems that the hypopharynx has a complete response, but there is some suspicious lymph node over the mediastinum. So we decide to give the surgical resection for the esophageal region and also 3D lymph node dissection, including the neck, but leave the hypopharynx alone, leave it alone. So, but we resect and anastomosis is do in the chest, not in the neck, because he had received a high dose radiation. We worry about the wound healing. So we perform either with the minimal invasive hysterectomy, that means the laparoscope gastric mobilization at first, and anastomosis in the chest. But in the meantime, surgical lymph node dissection was also given in the first stage. And the pathological stage for the esophagus cancer is T2 and 1. The lymph node over here is still positive, M0. This is the other example of this case. The third example is there is a 59-year-old male. He has hypopharyngeal cancer and esophageal cancer. The hypopharyngeal cancer by clinical staging is the T4B and 3. M is no distant metastasis. And the esophageal cancer looks quite early, is the T1B and 0 and also on 0. So in our hospital, they had the previous conducted the study for inductive chemotherapy followed by chemoradiation. So some oncologists like this protocol. So at first he received inductive chemotherapy at first. After inductive chemotherapy, he seems the response seems good. So after that, he received the definitive chemoradiation. After chemoradiation, the response rate seems good, but unfortunately, under follow-up about 6 months later, there is a lesion around the main tumor. There is an early lesion we like here, and the lesion is T1B and 0. Because this is a high risk, so we suggest give the photodynamic therapy for these patients. This is a complete response. So we follow up with the lymph node metastasis. We will give the further chemoradiation follow further. This is the third case. So the experience of the synchronous cancer in our experience is not so much. We here from since our correctional cohort, there is 800, around 900 cases. Around our received the surgery in our cohort, and around these patients, only 31 patients has double cancers. It accounts around 3.3% of the cases, and half of the patients have the esophageal cancer in the middle or lower third esophagus, and half of the patients have the upper third. And I had mentioned that the surgical resection, and for treating these patients, the policy is that once is locally advanced, including also for the hypopharynx or head and neck or for the esophagus is locally advanced. We will further give the chemoradiation and to see the response. If the complete response, we will with the head and neck complete response, we will preserve the function. But if the response, the residual tumor, we will give the surgical resection. But for the esophageal cancer, most of the cases receive the neoadjuvant setting, followed by surgical resection. So from this case, because my assignment topic is infracardiac, so I have to main focus on the middle and lower. Among the double cancer, just only 5 cases has a synchronous, and 11 cases is a metaconus. That means that esophageal cancer developed after the head and neck cancer was treated. So it was simply handled according to the principle of esophageal cancer, and most of the case have received the anastomosis in the chest, and the leakage rate quite low in this series. And after no matter is the upper third synchronous melanomas, most of the case we will give a neoadjuvant setting, then followed by the surgical resection. Surgical resection is laparoscope and thoracoscope based, and according to the tumor location. If the tumor location is below the aortic arch, we will perform intrathoracic anastomosis. If the tumor is above the aortic arch, because we worry about the resection margin, we will anastomosis in the chest. And because with the introduction of minimal invasive surgery, the surgical incision can be minimized. That will help to reduce the major surgical complications, such as pulmonary complications or anastomotic leakage. And this is our published data, as compared to traditional thoracotomy or laparotomy. The use of thoracoscope only can reduce, but with combination of thoracoscope and laparoscope, the benefit can be more significantly and more obviously observed. So this strategy will give us the advantage to handle the patient with such difficult disease. The patient can be more easily handled after the post-operative period, and more faster recovery. So it will give us the more chance for receive the further additional therapy. Usually, the patient traditionally receive the tri-incision, but from our experience, we moved some case to intrathoracic. That means Ivory-Louis particularly. This Ivory-Louis has some advantage. Is that each of the we mobilize in the abdomen and pull up the gastric tube in the chest, and there is the less tissue trauma around the airway, so the patient can have the faster recovery, including we will show the data. This is our analysis for this year. We have performed for the total 9 cases. The total is around 300 cases of total thoracic and laparoscopic approach. We exclude the adenocarcinoma. We can see the squamous cell carcinoma, and most of the cases is tri-incision because the most is the high location. But 1/3 they receive the Ivory-Louis. So we just for time limit. So we just see directly. We can see compare the Ivory-Louis and tri-incision, the ventilator and the ICU stay, and also for the vocal cord pulse is less in the Ivory-Louis, and overall survival there is no so difference. But the disease-free survival is even better in the Ivory-Louis. So when we perform the anastomosis in the chest, it will not compromise the survival. So this is the same result. We focus on the middle and lower cervical tumor. We can see the post-operative state and the vocal pulse was similar, and the survival is also different. There is also some survival benefit of the Ivory-Louis. Even attribute can be explained because Ivory-Louis will trim off the more the gastric tube during the anastomosis, after the anastomosis, because we found there are several cases has lymph node metastasis in the abdomen. So if we trim off the more gastric tube, then maybe there is a factor to reduce the local recurrence. So maybe some advantage with such approach is possible. And this is the survival analysis. We can see that the disease-free survival, the surgical approach, and the multivariate analysis is a factor influence the progression-free survival stage, and open method is a significant factor. So every sequencing is good for the patient with infracarina and with synchronous with head and neck cancer. It's a good option to prevent the radiation associated poor wound healing, and also have the less vocal palsy and the surgical result. Your equipment or you get better, and you even have the less tumor progression. But for the for the patient with a high level, here we the try incision is the option, is the standard treatment. Because now we have also similar experience. We have performed laparoscope gastric mobilization and thoracoscope pneumatization. This is the case, the total laryngopharyngeal esophagus. So we mobilize the gastric. We can see you can see the gastric tube can be pulled up to the neck and perform anastomosis. We have performed such a total laryngopharyngeal esophagus with so-called laparoscope approach around 14 cases, and only one case received the front anastomosis because of the inadequate length. And for the other case, the length of the stomach is sufficient for anastomosis, and we do not perform the supercharge of the vessel. And the wound healing seems good. The leakage rates occur in 3 patients of our series. And for the early agent, there is several offshoots of endoscopic close operation surgery, such as ESD, photodynamic radiofrequency. These are an option. We are case for especially for the patient after chemo radiation to be remission and early recurrence is an option with photodynamic therapy, such as the earliest case, and now the survival has survived over 9 years. This is the case we all do the photodynamic therapy. The cancer-specific death is 80% in 5 years, and compared to the esophageal, the survival is not so different. And this is another option of ESD. So ladies and gentlemen, it's our conclusion from experience. For patient with double cancer, we will try our best to functional preservation for those patients. If it can handled by chemo radiation, we will achieve the complete response. We will preserve the function. Otherwise, we will give the surgical resection. And minimal invasive esophagectomy, algorithm can be good for the lesion below the aortic arch. The tri-incision can be done for the patient above the aortic arch. If the necessary, total laryngopharyngeal esophagectomy also can safely perform for such patients, but we were put in the last choice for the patient. After all, it is not give much suffering for the patients. And for the early lesion endoscopic growth operation, may be good for the early lesion. Thank you for your attention.